pulmonology, and cardiology, and even dermatology sometimes if the diagnosis was right. So tonight, I thank Boehringer for supporting this meeting, which looks into the diagnosis and new advances in managing interstitial lung disease in patients with connective tissue disease, and looking specifically at certain diseases. Tonight, we have three great speakers. Gives me great pleasure to introduce our first speaker for tonight, my friend, my brother and colleague, Professor Ahmed Bajamal, who is a consultant rheumatologist at Dr. Samal Habib Hospital in Dubai. He's a professor of rheumatology at Al-Azhar University, Cairo, Egypt. He's an accredited Euler musculoskeletal ultrasound teacher. He participated as an organizer, speaker, instructor, and trainer in many national, regional, and international rheumatology conferences. He is an active member in GRAPPA network, ACR, and had many research articles published in national and a lot of international journals. He had many posters, abstracts presented in ACR, EULAR, APLAR, and RLAR. So without further ado, Professor Ahmed, the floor is yours.
Thanks, Dr. Walid, and thanks for ERA for presenting this meeting. It was a very good, very important topic already, which is the scleroderma. Can you see my screen? Okay, so the subject of my talk will cover the basics behind the scleroderma or systemic sclerosis as a disease. This is my disclosure. The agenda will include some historical backgrounds about the scleroderma itself, and running through the burden of the disease, and hence about the general pathology of the scleroderma, with passing through the clinical spectrum among the cutaneous and extracutaneous manifestation of the disease itself, plus the updates regarding the diagnostic criteria and the disease activity. If we look back in the history regarding the scleroderma or systemic sclerosis, we found the first description about the scleroderma is already limited to the skin changes, just describing the most alarming feature of the disease, the most dramatic part, which is the skin thickening and fibrosis. That's always firstly known as scleroderma. And in the history, there is a great link, and I think it is still valid till today. There is a link in the history between scleroderma, systemic sclerosis, and the Italian side. The first case description about the scleroderma is really described in Napoli, in Italy, in 1753. And again, the first physician to describe the scleroderma as a disease, it already happens again in Milan, by Dr. Fantonetti in 1836. And all of us already know that Professor Marco Matucci is one of the most active rheumatologists in scleroderma in Europe from Bavaria University. He's already working mainly in scleroderma, and he really was the head of the EUSTAR, which already is the subgroup of the EULAR related to the scleroderma as a disease. So there's always a link between scleroderma and Italian side. Scleroderma is a huge problem because already she has a significant disfiguring, disabled, and potentially fatal, and already have another different phases or heterogeneous presentation regarding the organ involved and its manifestation. And at some time it is difficult to diagnose because it may take time to complete the criteria for diagnosis, and they have a variable course. Sometimes it goes for a remission, a stationary course, or sometimes to continue to be progressive, and for sure it is incurable. Moving to the second part, which is the disease burden. The disease itself usually is the incidence about 7 to 20 per million per year, which is a rare disease. And the incidence and prevalence usually changes or varies between different countries and region, but still commonly affecting the women aged from 25 to 55 years. And the most important that we have up to 90% of them could develop idiopathic lung fibrosis at any stage of the disease. And 1 in each 4 patients with scleroderma have a significant lung disease after only 3 years of the diagnosis, which has a very significant impact on the survival rate, with the median survival rate with patients with scleroderma with ILD is about 5 to 8 years old. And remains finally, the scleroderma idiopathic lung disease is responsible for about the 35% of the mortality of patients with scleroderma, representing now the most common cause of mortality among patients with scleroderma. So what about the pathological definition? The pathology of scleroderma may vary based on the organ affected, but there is general rules in the pathology of scleroderma. There is 4 happening pathological scenarios happen together or in sequence, starting by vascular dysfunction, autoimmunity, inflammation, and fibrosis. And all of them happens at different regions, from the blood vessels, skin, synovium, skeletal muscles, and internal organs. This happened actually due to interplay of different regions of genetic predisposition linked to HLA and non-HLA genes, plus some changes in the epigenetic characters and factors, plus some environmental triggers like silica or some drugs or viral infections to initiate the cycle of scleroderma pathogenesis. The cycle usually starts in the blood vessel. There is, for unknown reason, we have damage in endothelium with subsequent activation of the T lymphocytes, which migrates outside the blood vessel towards the subcutaneous or towards the skin. Leaving the T cells and macrophage together leads to interaction between them with a subsequent release of the inflammatory mediators and activation of the B cells with antibody formation. The pro-inflammatory mediators goes secondary to stimulate the most important acting cell in scleroderma, which is the fibroblast, leads its activation and maturation towards the myofibroblast, resulting in the end stage pathology, which is the extracellular matrix deposition, which is the hallmark of the disease. It leads to sickening and the subsequent fibrosis, which is the hallmark of the disease of scleroderma. Coming to the clinical spectrum of the disease, scleroderma itself, it could be classified in 2 main parts. One, it is the systemic sclerosis, which is the main disease, and we have some group of heterogeneous diseases, which is called the scleroderma-related or scleroderma variants, which have a common character, could be have a connection with the pathogenesis of scleroderma. Systemic sclerosis itself is classified into 3 different stages based on the extent of the skin involvement. We have the early or thin scleroderma without any significant skin fibrosis based on the presence of the positive markers, Raynaud's phenomena, and significant capillaroscopy changes in the capillary veins. Going to the limited, which have a limited skin hardening or involvement, just limited to below the elbow and knee, either type 1 or type 2, and we have the diffuse one, which have a diffuse involvement of the skin above or proximal to the knee or the elbow. Another variant from the scleroderma, which is a crest syndrome, which is composition of the calcinosis and Raynaud's phenomena, associated motility, sclerodactyly, and telangiectasia. And some authors believe that it is already a part of the limited scleroderma, not as a separate entity. And we have also the morphia, either patchy or linear fibrosis, which usually happens in juvenile ages and presented as a hemifacial fibrosis or patch of fibrosis, which also could be an scleroderma variant. The skin in scleroderma passing in 3 important phases: the edematous phase, indurative phase, and atrophic phase. In the edematous phase, the hallmark was here is the inflammation and the edema of the skin, leading to the feeling of tight or puffiness of the finger, especially in the morning, with pitting or non-pitting edema around the finger and digit especially. This is the edematous phase. The second phase, which is the induration by the progressive deposition of the extracellular matrix, is thickening and tightening of the skin with shining of the skin, and already the main component at that time, it will be pruritus of the skin with some inflammatory changes. And there's two important features already we are seeing in the indurative phase, which is the facial changes. We have the expressionless, pinched expressionless phase, and we have the what is called the salt and pepper appearance into the mixed areas of hyperpigmentation and hypopigmentation, especially around the hair follicles. After several years, there is thinning of the skin and atrophy of the dermis, which leads to softening of the skin, what's called the atrophic phase. And at that time, the most presenting symptom or faces of the patient will be telangiectasias, which are around especially the face as we are seeing here, the red marks of the dilated capillaries, loop, and distended venules. So the course of the skin scleroderma passing into a progressive increased thickness, especially over the first 5 years. And by time there is decrease in the thickness going to the atrophic phase, usually ending to after 10 years to reach the lowest level of skin thinning atrophy after thickening of the skin of scleroderma patients. The second common cutaneous manifestation, which is the calcinosis due to position of hydroxyapatite under the skin, usually happening in the extensor surface and around the elbow and the cranial bursa and the extensor surface, and usually followed secondly to minor trauma as a predisposing factor. Away from the cutaneous, we have a clinical spectrum of the disease, extracutaneous involvement in scleroderma. Starting from the vascular system, we have the hallmark of the disease about the peripheral vascular system, the Raynaud's phenomena. Raynaud's usually present up to 95% of patients with scleroderma, either in the limited or the diffuse type, usually affecting the toes and the fingers, and may affect in severe cases the nose, ear loops, and the tongue. Another part of the vascular involvement is the pulmonary hypertension, which is a very fatal involvement in cases of the scleroderma. And the scleroderma could affect the pulmonary vessels either in two types. We could affect the primary pulmonary hypertension type 1 due to the vascular involvement, and also could be causing pulmonary hypertension type 3 based on the presence of ILD as a cause of the pulmonary hypertension. The heart involvement could have myocarditis and pericarditis as a primary involvement, or we have also some kind of arrhythmia, and we have also a secondary causes due to scleroderma as in pulmonary and systemic arterial hypertension. For the musculoskeletal symptoms, actually there is mainly involvement as a symmetrical polyarthralgias, not definite arthritis. But if we go back to some research articles, we have paper published almost in 2005 by Anna Maria. She revised patient with scleroderma using ultrasound. She defined a typical picture of synovitis, and erosion looks like rheumatoid arthritis. So we have a variance of arthritis in patients with scleroderma. May in some time gives the picture of symmetrical arthritis like RA, but it's difficult to ascertain the swelling and synovitis based on the palpation alone due to the hardening or thickening of the skin. The most famous here for the tendon, which is a tendon rub due to the fibrous deposits around the tendon and the overlying fascia. It's due to the specific limitation of movement with the sound of rubbing tendon during friction movement. For the bone, the most significant imaging finding for scleroderma, which is the tuft resorption or bone resorption or acrosteolysis, that's believed due to a vascular origin due to something related to osteonecrosis. And as I said before, some patients may develop a typical picture of erosive arthritis like rheumatoid arthritis. Skeletal muscles, most of the skeletal muscle symptoms related to disuse atrophy and secondary to joint disease, and we have 20% of patients with primary myopathy. For the GIT, the hallmark here it is the disc motility starting from the esophagus to the stomach to the small intestine and the large intestine, causing different symptoms based on the region. Starting from the esophagus, we have already esophageal dysfunction developed about in 80% of patients. We have the paralytic ileus in the small intestine, tonsil obstruction, malabsorption, and already some diverticular distension even in the large colon due to this motility in patients with scleroderma. For the pulmonary involvement, I just go in a few slides because I will leave it mainly for my colleague, Dr. Rajai. So, as we said, lung is a major cause of morbidity, with fibrosis also could happen in both types of diffuse and limited scleroderma. It usually affecting non-white and topoisomerase positive patients. And I just need to go through an updated approach, which already published this year in the last version of the Kelly textbook for rheumatology, about the approach of lung disease in patients with scleroderma. Starting by screening, if you have a new patient with scleroderma, you have to go for a basic screening, including the history, exposure, echo, pulmonary function test, and the high-resolution CT scan. And based on this result, we have to move forward based on the result. If we have all of them are normal, we have to repeat on a yearly basis, and pulmonary function test every 6 months only for high-risk group. And if you got an abnormal forced vital capacity or the DLCO, but normal high-resolution CT, we have to repeat this test after 4 to 6 months and evaluate the for alternative cause of this respiratory limitation or respiratory symptoms. If you got an abnormal forced vital capacity and DLCO with abnormal high-resolution CT, but less than 20% of the extent of fibrosis, we have to repeat the function test again in 4 to 6 months and consider new high CT symptoms progressing. If we have a significant reduction in the forced vital capacity or DLCO up to 15%, or worsening of the high-resolution CT, at that time we have to go for medical treatment for ILD. In case we have abnormalities in both the pulmonary function test and the high-resolution CT with significant fibrosis over 20%, and the active alveolitis was ground glass pattern at that time, we have to go directly for the treatment. And also, it's very important that we have a decline in DLCO about 15%, and DLCO is less than 55% with normal forced vital capacity. So we have to look about the vascular part, and we have to think about the pulmonary vessels, and we have to refer to right side heart caths for pulmonary hypertension. In case that patient have an unexplained dyspnea, a typical CT pattern finding or atypical symptoms like hemoptysis, here that we have to go for special testing, including the PAL fluid analysis and lung biopsy. It's a very nice approach to cover the different patterns in patients with scleroderma. Coming to the kidney, usually the kidney is not significantly affected early in the disease, but we have the most fatal, which is the scleroderma crisis with abrupt onset of accelerated hypertension and accelerated oliguric renal shutdown or renal failure with accelerated hypertension. This usually could happen with long-standing patients with scleroderma, usually associated with headache, visual symptoms, blurring of visions, and retinopathy, seizures, and acute dyspnea due to sudden left ventricular failure. There is a high link between the scleroderma and endocrine dysfunction. In spite of this, could be subclinical in most of the cases, but there is a significant percentage of patients with scleroderma have hypothyroidism, often clinically unrecognized, and there is also evidence about the antithyroid antibodies among patients with scleroderma, and also the basal and stimulated serum prolactin levels are increased in women with systemic sclerosis. This could be related to subclinical hypogonadism. For malignancy, the published frequency of cancer varied from 3 to 7%, and lung cancer is significantly more frequent, alveolar cell carcinoma and lymphoproliferative malignancies. For the antibody testing, to diagnose or define the subcategory in scleroderma, it is very important to test the ANA profile and the other sub ANA test for scleroderma, because we have a great link here between the pattern of scleroderma involvement, and also the antibodies. As you can see here, the anti-CSL70 usually linked to the diffuse scleroderma, and we have the centromere P or C linked to the limited scleroderma, and the RNA polymerase 3 is linked to the severe skin diffuse and also linked to the scleroderma renal crisis. So defining the pattern of antibodies is usually significant to define the spectrum of the disease. Coming to the diagnostic criteria, which is the most recent, published in 2013 in collaboration between the EULAR and the ECR, the classified 8 different scored domains and gives them all of them a weight score, starting from the skin thickening at the fingers and the skin lesions and fingertip lesions, telangiectasias, abnormal nail fold, pulmonary artery hypertension, Raynaud's phenomenon, and the antibodies related, and gives them, all of them are scored. If the patient already gave a score of 9 or more, reclassified as having scleroderma. This criteria already have a significant good specificity and sensitivity up to 0.9, 0.2 in comparison to the older version of the criteria, but still there is still a big limitation in diagnostic criteria. As we are speaking about patient in early phase of scleroderma, we don't have a significant skin involvement. It will not fit the full 9 points of the score. So such patients have already a positive marker, and they have just a Raynaud's and have a positive capillaroscopy finding related to scleroderma. So this group of patients still cannot be classified to scleroderma based on the criteria of 2013. So I think this is area of investment. Still, we need some updates to cover the early diagnosis of patients with scleroderma. Coming to the most important, how to measure the activity in and severity in scleroderma. We have some general assessment scores based on the disease domain itself, as the most famous, the modified Rodnan score to define the skin involvement. This is mainly for the skin, and visual analog scale for the disease itself. We have assessment scores for the heart, pulmonary hypertension, and 6-minute walk test for the efficiency of the pulmonary circulations and the pulmonary function test. But in 1999, we have the first composite score done already by Metzger team in 1999 and already updated in 2003. This scale based on scoring of all the disease domain in 4 different groups, starting from 0 for normal to 4, which is the end stage, for each organ system involvement, including the general measures, along with peripheral vascular system, skin, joints, tendon, GIT, tract, lung, heart, and the kidney. It's very practical that we can score the patients in 4 groups, giving them a figure number that can give an idea about the whole domains affected of the disease. As you are seeing here, this is already the different stages from 0 for normal, 1 for mild, 2 for moderate, 3 for severe, and 4 for end stage. And on the left column, you can see general peripheral vascular skin, joint, tendon, muscle, gastrointestinal tract, muscle, intestinal tract, lung, and heart. To define all of them based on the severity of the disease, we can score the disease activity. So my final home message is that scleroderma have a wide spectrum of clinical manifestations that reflects the underlying pathogenic triad of immune dysregulation, microangiopathy, and subsequent systemic inflammation. There is marked patient to patient could be variability as regards the clinical and even the immunologic manifestation of the disease and in terms outcome. So fibrosis is still the most important manifestations, but it has already happened secondary or in the stage for the matrix macromolecule depositions from activation of the myofibroblasts. This is my references, and finally, thank you.
Thank you, Professor Ahmed, for a very well-structured and nice presentation. We agreed to leave questions at the end But I might have one burning question for you.
Okay.
So, I mean, how, maybe you could answer this, or maybe Raja could add as well. In regards to Rodnan skin score, especially with female patients,
Yes.
it is really difficult to assess. And I do remember having some female patients who needed assessment and they refused me doing the skin scoring. So I referred them to some of my female rheumatology colleagues, and they don't get the right Rodnan score. So how important is the Rodnan score to the whole formula if you don't get it right?
Let me remember almost 11 years back, I went to Eastar. I spent about 7 days with Marco Matucci and Damianov to teach me how to do the Rodnan score. So it was very critical that we have to be assessed even every point to pinch, and if you are not doing the pinch right, you will get a false score. This is very important at that time to present the spread and severity of the disease. I think the area of upgrade here should be related to the nurses, trained nurses. If we have a good rheumatology nurses trained for us, I think she can help us a lot in this. Because as you said, most of the females will refuse us to do whole assessment of the skin with such method to score it. And as long as the disease is more prevalent in females, I think this is already a very important point you raised there. We have to invest in rheumatology nurses to cover this assessment score.
Thank you very much. Okay. Raja, you don't have anything else to add? You want to go straight?
Yeah, I agree with Dr. Abu Gamal. So it's a surrogate of internal organ involvement. So the more the skin improves, the more the internal organ improves, and vice versa. We used to have a workshop actually in Michigan run by Dinesh Khanna. It's a certified, I think, workshop where they teach you how to assess skin. I think it's a good initiative to have it in the future here to teach our nurses and colleagues in rheumatology, and you can get, I think, a certificate for that. Because sometimes it's very challenging, especially if you assess the skin disease later during the course of the disease. And sometimes you think it's thickening, and it's called tethering. It means the skin is like so thin that you think it's thick, and it's not usually the how much you peel the skin, it's how you feel the thickness of the skin. So I think it's very good to have this in the future as one of the workshops in one of our meetings.
Yes.
Thank you very much. So we stay with you, Dr. Rajai Namas. Will be our next speaker. So Dr. Rajai is a friend and colleague and a brother. He's an MD. He's a section head of rheumatology at the Medical Subspecialties Institute at Cleveland Clinic Abu Dhabi. Prior to joining Cleveland Clinic Abu Dhabi, Dr. Namas served at the University of Michigan as a Cleveland lecturer for 2 years and was supported by National Institute of Arthritis, musculoskeletal skin diseases mainly. He was then promoted to clinical assistant professor at the University of Michigan. Dr. Namas received his medical degree from the University of Tripoli, Libya. He completed his postdoctoral training at the University of Pittsburgh, Pennsylvania. He was followed by his residency in internal medicine, the Hurley Medical Center in Michigan State University in Flint, Michigan. Dr. Namas completed his clinical and research fellowship in rheumatology at the Wayne State University, Henry Ford Hospital in Detroit, Michigan. He is currently active in numerous research projects focused on treatment strategies, measures, and outcomes in translational studies and potential laboratory markers for disease activity. He has multiple publications and awards in the field of rheumatology and is a reviewer on multiple peer-reviewed journals. Dr. Namas is a member and fellow of the American College of Rheumatology and American College of Physicians. So without further ado,
Thank you, Dr. Waleed, for this nice introduction, and I'd like to thank BI for the kind invitation, and thanks, Dr. Abu Gamal, for the nice overview about systemic sclerosis. So today I will be highlighting prevalence. I will talk a little bit about the UAE. We have a registry that we implemented in 2018, and with the help of all colleagues in the region, now the registry is closed. We're still recruiting. So I'll give you a little bit updates about it, and then we'll talk about screening, and then we'll talk about the management of systemic sclerosis, ILD, followed by, we'll go over the census trial that led to the FDA approval of OFIV. So my disclosures, I'm contracted by BI to conduct this session. I have no financial interest in BI. So as Dr. Abu Gamal highlighted, I don't know if I have control on this. Next. So how common is ILD in systemic sclerosis? And I think Professor Abu Gamal clearly highlighted the burden of the disease internationally. And actually, I'm sure most of us have one patient that we are challenged when we treat. And for a fact, we know that systemic sclerosis is a rare disease, but a very challenging disease. And most of the time we are challenged whether with diagnosing the patient or even managing the patient. I started with this slide. It sounds easy sometimes to diagnose the disease, maybe in the middle when we have symptoms, but sometimes early during the disease, very challenging to have a handle of whether the patient has systemic sclerosis or not. But we are fortunate that we have good screening tools in systemic sclerosis. There's a lot of clinical symptoms that we can look for. And I don't think any of the diseases that we treat have this high sensitivity. So if you have sclerodactyly, means skin thickening distal to the MCPs, if you have Raynaud's and a positive ANA with nuclear pattern, confidently more than 95% you can say that the patient has systemic sclerosis. Next. If those are absent, I think you should think of something else. You should think of scleroderma like skin disorders. And as Dr. Abu Gamal highlighted, the ACR came with a very nice criteria to no, I think we're jumping here. No, go back. The ACR in 2013 came with a very nice classification criteria. It was the first initiative to diagnose patients with systemic sclerosis. Skin thickening was one of the main findings. It's a weighted criteria, as Professor mentioned. Still, just a clinical hint. Still, though it says that if you have sclerodactyly proximal to the MCPs, you should have scleroderma. Even if it's distal to the MCPs, you should also think of early scleroderma or an evolving scleroderma. Puffy finger is very challenging. We see this a lot. Most of the time, we diagnose them with rheumatoid arthritis or lupus because they have a positive ANA, and down the road, when we follow them over a year or two, we realize that, no, this is more a scleroderma-like picture. Pulmonary hypertension and interstitial lung disease were also implemented as part of this criteria. Again, this criteria has, as Professor mentioned, that it has goods and bads. The bad part of it that it doesn't diagnose the early patients, and sometimes those patients are missed. So just going back in 2000, just talking about the prevalence in the UAE, in 2017, when I moved to UAE, we went through the ESR, and we approached all physicians in the UAE to form a registry, and successfully last week we closed this registry, and now we are in the preparation of the manuscript. Just want to give you an overview. We have about 190 patients in the UAE with scleroderma. 55% of them are from the UAE. The majority have diffuse cutaneous systemic sclerosis, about 70%. 30% have limited cutaneous, and 20 have morphea. Out of those, of the diffuse, 70% have ILD, and out of the limited cutaneous, only 20% have ILD. And we also looked at different analyses. It's a very comprehensive registry, and hopefully soon we'll have the first published paper of scleroderma assessing the incidence, prevalence, and comorbidities and management of scleroderma in the UAE. And hopefully soon we'll have the paper. I'll share it with you. ILD develops early in the disease, and as Professor mentioned, about 90%. If we screen all patients with the scleroderma at baseline, we'll have a form of ILD. And the first year is the very main, what we call the window of opportunity in scleroderma, that you need to be very aggressive in screening those patients with their skin, whether do a good skin assessment, because this is, as we spoke earlier, this is surrogate that tells you if the patient is prone to develop an internal organ involvement, and you should also be aggressive with screening. GI involvement is very common also. We usually miss it. Other than heartburn, there's a lot of lower GI involvements, including diarrhea and malabsorption. So pulmonary involvement, for a fact, is crucial in the first year. And as soon as I inherit the patient from the UE, the first thing I do a high resolution CT, and I do a PFT, whether he had it or whether he had one recently or not, just to clear your mind and have a baseline CT, because this down roads affect the management and affect the prognosis. Next. And as mentioned, 90% of patients with scleroderma develop ILD, and 1 out of 4 of these need to be treated. Why it's important to treat? Because the ILD is the most common death-related outcome. 35% of those patients results in high mortality, and it's a progressive disease, and it results in high burden on the patient, requiring oxygen, and whether it's financial burden or personal burden. Next. That's me. Why it's challenging to diagnose patients with systemic sclerosis early. It's a heterogeneous presentation, as mentioned, puffy fingers, Raynaud's. I mean, in the UE, it's not common. It's uncommon to see Raynaud's because of the weather, but still, we do see it. Non-specific symptoms, sometimes they come with fatigue. We sometimes diagnose them as other diseases that we treat more commonly, like lupus or Sjogren's, or sometimes they come with a rheumatoid-like picture. And over years, then you realize that no, the patient has a kind of a scleroderma. So early and regular screening is an essential part of early detection of systemic sclerosis before significant progression occurs. As mentioned, there's the forms of scleroderma, limited and diffuse, and always when we learn during residency that patients with limited cutaneous are more prone to pulmonary hypertension, and patients with diffuse are more prone to ILD. And this is always present in our mind that when patients with limited cutaneous systemic sclerosis come to your clinic, sometimes you bypass the lungs and you just focus on the heart, and the opposite. And I think, if we look in real life, I mean, this is not the ideal way. I think both of them should be screened as equally, and this is reproduced in trials, and I think in our practice and in the registry actually that we formed, that we have about maybe 30% of patients with limited that have ILD, and you don't want to miss these 30%, because down the road it really makes a difference, with managing these patients. ILD symptoms, what are the most common that we see are dyspnea and exertion, and sometimes fatigue, chest pain, and they're not all non-specific and not always present. I mean, if we look at the physical exam, most of the time, if it's challenging sometimes to hear crackles, mainly basilar crackles, as we mentioned, sometimes most of the diseases, most of the patients are females and they don't like to cover, and usually you listen to their lungs from above the abaya. So it's very challenging sometimes to hear crackles as you expect. Next. And again, so you cannot rely only on the clinical symptoms and the physical exam, and you should always be ahead of things. And I think ILD is a crucial part as a crucial screening test here with assessing patients with ILD. High resolution CT is the gold standard, and it's a non-invasive method. You should have a baseline high resolution CT. I know patients, sometimes they go because they're desperate about the disease. They know that it's very challenging to treat, and sometimes they go from a physician to physician. And for a fact, if the CT is more than 6 months to a year, I usually repeat it at baseline. It allows the detection. You can stratify the disease, whether it's mild, moderate, severe. You can have a baseline test, and usually what pattern you see is the NSIP pattern, about 78%. And UIP is less, not like what we see in rheumatoid arthritis or Sjogren's. And it scores the disease, assess the disease distribution, the extent of fibrosis. So it's very useful in having managing having an overview of the disease and the burden of the disease. Again, so these are the screening tools that, as soon as I see a patient, I do a high resolution CT looking for ground glass opacities, fine reticulations, and other findings assessed by the radiologist. I think you should have a good relation with a pulmonary radiologist because this, can help you with assessing the extent of the disease, and it can help you with also when to start the medication, because this is the first question that patient asks. Pulmonary function test, you should have a baseline PFT and looking for FVC, whether this is a restrictive or obstructive. FEV1 over FVC also is helpful. I look at TLC, it's the total lung capacity. It's a very good indicator of the overall lung function. And you should look also at DLCO to know whether this is it more a restrictive pattern or there's a component of pulmonary hypertension. Labs that I look at, that I order usually are BMP. I order uric acid level. I use the detect algorithm to detect pulmonary hypertension. And if there's a high concern about pH, I refer it to a cardiologist who's specialized in pulmonary hypertension for a right heart cath, because sometimes it's challenging how much you increase the biologic DMARDs and you maximize therapies, but still the patient is short of breath, and sometimes it's just treating the pH with the ILD is the key. Next. Staging is very important. As a rheumatologist, I don't do it, but this is I think the benefit of having a multidisciplinary meeting, because without staging, you can't know exactly how aggressive you should be with management. And the CT can stratify the patient into 3 categories, whether is it a limited disease, which is less than 20% involvement, more than 20%, or it's intermediate. And this where comes the pulmonary function test to stratify whether the FVC is less than 70% predicted, which tells you that this is more an extensive disease. You should be more aggressive with initiating treatments and having serial follow-up visits, or is it a limited disease? And this is very crucial to have a MDT meeting in your hospital with having a pulmonary doctor and a pulmonary physician and a radiologist. And this is the journey, this is the path, how the patient, so the onset, so it starts with Raynaud's, usually breathlessness, some non-specific symptoms. Usually the patient ignores it, he just delays the presentation, he thinks they're just transient symptoms that he can just ignore for a while, and then he presents to a primary care doctor. Raynaud's, most of the time when you have Raynaud's, they send to either a rheumatologist or a vascular doctor, or sometimes a neurologist. And then, he becomes misdiagnosis, sometimes rheumatoid, sometimes lupus, sometimes, fibromyalgia. And then he goes to another specialist, gives him another diagnosis. And then, so series of referrals, which, the patient lose interest and lose confidence. And then at one time he comes and somebody tells him, oh, he becomes more short of breath. And at that time he's diagnosed with ILD, and then a very long journey, and then he's managed with different disease-modifying drug. But at the point he reaches this box on the left side, I think sometimes the treatment is very delayed, and your hands are so tight that you don't know what to do to the patient. And I think the apply here is the the window of opportunity that we apply in rheumatoid and other diseases should be applied in this disease, that the earlier you treat, the better outcomes and the better impact, on the patient's life. Next. And again, this is the journey. If you look at, scleroderma ILD is one of the top 5 that, there's a very long delay between the initial diagnosis to the diagnosis of ILD. It takes about, I think, 9 years. And then from diagnosis of ILD to development of progressive ILD, about 12 years. And then from progressive to ILD detection by physician takes about, 9 months, it's not years, 9.6 months. And then, from progressive to death, it's about 33. So it's a very long journey, I think, and with the efforts of awareness among patients, among physicians, among primary care physicians, I think we can delay this gap and improve patient lives. Next. There is still unmet needs in the clinical guidelines to support the early recognition. As mentioned, the criteria that we mentioned is more for research, but we use it clinically to further support our clinical impression. But still, we don't have a an excellent criteria or recommendations that can tell us, whom are the patients that are at a very high risk, whom are the patients that we need to be aggressive, and it gives you a guideline tool that would same what we have in rheumatoid or psoriasis or other diseases. Next. There's a proposed algorithm. This is from in 2015, that if you have a systemic sclerosis diagnosis, you should do a clinical exam. We didn't talk about capillaroscopy. It's very important. I mean, if you can do it to diagnose the disease earlier, that will be very beneficial. In addition, we have a very large autoantibody profile, which can stratify patients also. And you should do a PFT with DLCO. We don't do a lung ultrasound here. And you should do a high resolution CT. And then this defines the disease, whether the patient has ILD versus no ILD. And then you go, if there's no systemic sclerosis ILD, you do a PFT every 1 to 2 years, and if you see any decline, delta change in the FVC or DLCO, then you should do a high resolution CT. And if the patient has systemic sclerosis, you should treat them, and then you should do a PFT with DLCO every 6 months. We use this algorithm. There's another algorithm also we use. If you go next. Again, if you have systemic sclerosis ILD, lung auscultation every visit, which we do, PFT, and then every 3 to 6 months, you should do a PFT for symptomatic, and 12 months. And if you see a progression disease, you should do a high resolution CT. And if it's a limited disease, you do the same thing every 3 to 6 months. And if it's stable for 5 years, you do a PFT every 12 months. Very, I mean, if you apply this clinically, it's very challenging. And, we have 100 patients that we follow with scleroderma, but I told you about 70% have ILD. So it's very challenging to apply this algorithm during your daily practice. Next. I think this is the very most challenging question. And whenever we see a patient with ILD, we ask ourselves, do we wait or we should initiate treatment? And if we sit with 10 rheumatologists, I think you'll see conflicts in the whether to wait or to initiate, and what to initiate also. It's conflicting. And we see this during our MDT meetings when we discuss patients with new onset systemic sclerosis ILD. You can see that there's a discrepancies in opinions, that some of them, they say no, wait, but start CellCept, start rituximab. So you see discrepancies in the opinions. Next. And as you can see also, there's discrepancies from different guidelines or recommendations. In 2009, this say if you have a limited disease or diffuse disease with dyspnea, just go ahead and start medications. If you have a decline in the FVC delta change more than 7% or DLCO more than 10, you should go ahead. Very tricky. Sometimes the patient comes with a PFT from another hospital, and you do a PFT in your hospital, and there's usually there's an test variability between different PFTs, and which you should account for. For example, for a DLCO, it's more than 15%. I think for an FVC, it's about 5 to 10%. And it depends on how much confident you are with reading PFTs. So it's very challenging. It's not straightforward. In 2016, Volkmann also came with another notion that symptoms that cannot be explained, which is very vague. And if you use it clinically, it's very hard to apply. 2018, another guidelines came, more than 20% extent, which we know from the stratification of the high resolution CT. And then Dinesh in 2018, he said worsening extent, high resolution CT, and symptoms or declining PFT. What's declining PFT? It's very vague also, but how much decline in the FVC? Is it a clinical plus imaging? It's very, very challenging, and that's where the role of sitting with a pulmonologist and sitting with a radiologist give you that confidence that, okay, now we should start the treatment. You should, I think this discussion, the brainstorming of when to start should be initiated with 3 physicians on the table. Next. Treatment options. Currently, there is no cure, and we don't have, other than OFIV, we don't have FDA-approved medication. Like recently, Actemra was also had a recent FDA approval. There's no drugs specially licensed for systemic sclerosis ILD. Current treatments aim to minimize progression and reduce the impact, and there's no well-defined treatment algorithm. I'm sure all of us, we are challenged when we see a patient with the same, scenario. Next. Treatment algorithm. Again, there's no typical treatment algorithm, maybe initiated above presentation. If there's a decline, increase in the predicted FVC more than 10, or a decline in the HRCT more than 20%, we usually use non-selective immunosuppressive. This depends on our experience. I used to use cyclophosphamide in the past. Now I'm more comfortable with mycophenolate. Steroids, we are always cautious in scleroderma to trigger scleroderma renal crisis. So we don't use, we use steroids a lot. Methotrexate also, we have always this fear of worsening of the ILD. We use it, but always in the back of our mind, we are cautious about it. We use leflunomide actually a lot in my practice. Autologous high stem cell transplant was, I think, proposed in 2017. I think out of those 100 patients that 190 patients, only one had a stem cell transplant. Very stringent criteria to enroll those patients. So it's not a feasible, one of the feasible treatment options that we use as an initial part of the treatment of systemic sclerosis ILD. Next. And again, 2017, the EULAR recommended use of cyclophosphamide and stem cell transplant, which again, it's not something that we use when we see patients from the first time. This is something that we use in refractory patients. Next, due to the stringent criteria for enrolling these patients, what are the most commonly used treatments? Evidence. What's the evidence to support their use? Next. The most commons are, as we see in 2018, this paper came that looked at the USTAR database, which is the largest registry, and glucocorticoids was the highest, followed by cyclophosphamide, azathioprine, methotrexate, MMF, rituximab. And I'm sure if they change this, if they do this analysis in 2020, I think mycophenolate will be moved to the left side, maybe followed by cyclophosphamide. Next. And again, the 2 main treatment recommendations were either cyclophosphamide. Again, I think most of us are cautious with using cyclophosphamide due to the risk of high risk of side effects. Why don't you use mycophenolate? And this was supported by the scleroderma lung study 2, which reassured that this both works together similarly. And we prefer mycophenolate due to the lower risk of side effects. And in 2016, the stem cell transplant came to play a role, which I don't have that much experience with. Next. Emerging treatments. Existing treatments aim to minimize progression and symptoms, but do not modify the natural history of the disease. They're non-selective, just act globally on the immune system. And emerging treatments are more focused treatment on the course of the disease by targeting underlying autoimmunity. And the main hallmark of the disease is fibrosis, where TGF-beta plays a major role in the disease. Next. And for a fact, we know that there are multiple agents that are currently under in the pipeline. Tocilizumab was recently approved by the FDA for ILD. Honestly, I still am challenged which patient scenario to use tocilizumab. I still prefer CellCept and OFIV. It's still challenging which patient fulfill that package to use tocilizumab. But I have one patient on tocilizumab even before the approval by the FDA, which was refractory to multiple immunosuppressive therapies. Abatacept is also in the pipeline. Riociguat, and there's other monoclonal antibodies. Next. Next. So agents that target fibrosis, more specific, we have tyrosine kinase inhibitors, which is OFIV is one of them. We have pirfenidone, which have been in the market for IPF, idiopathic pulmonary fibrosis, for years. And we used to use it off-label in treating patients with ILD, systemic sclerosis, ILD, but now having nintedanib as an FDA approved, we more favor nintedanib as a first line. Next. And how did this come? The notion of nintedanib, it's a tyrosine kinase inhibitor. It also inhibits other growth factor derivatives, and it has a broader inhibitory profile than tyrosine kinase in systemic sclerosis. And this, I remember, when this study started, in vivo studies in mouse showed that. Next. Study showed that in mouse models, in vitro or in vivo, that it displayed an antifibrotic effect in scleroderma, systemic sclerosis, and as seen here, it decreased fibrosis significantly with increasing the dose. Next. So let's talk about the Census trial. I think this is the trial that led to the approval of OFIV a couple of years ago. Next. So it's a two-arm study. There's placebo and there's OFIV, 150 milligrams BID, and the primary endpoint was assessed at 52 weeks, and there were multiple secondary endpoints. Next. Age done in adults, age more than 18. Patients had early disease of systemic sclerosis from the first non-Raynaud's phenomena. This is an early disease, less than 7 years, and ILD on the chest was performed 12 months of screening, more than 10% extent of fibrosis, and they have moderate lung disease on FVC and DLCO. Next. Which patients were excluded? Patients with elevated ALT and ST 1.5 times the upper limit, bleeding, myocardial infarction, if they have thrombotic event, if they have digital ulcers, more than 3 digital ulcers, or history of severe digital necrosis, if they have significant pulmonary hypertension, and history of scleroderma renal crisis. Next. And permitted medications were prednisone, or they could be on mycophenolate or methotrexate. And we will talk a little bit about the medications when we look at the baseline demographics. Next. And these are the patients that were excluded, patients who were on prednisone more than 10, or they were on other conventional synthetic DMARDs, such as Imuran, hydroxychloroquine, sulfasalazine. Those ones, they should, within 8 weeks of randomization. But the ones that were excluded were cyclophosphamide, rituximab, tocilizumab, abatacept, leflunomide, tacrolimus, and newer medications such as tofacitinib and cyclosporin. And previous stem cell transplant were also excluded, and previous treatment with OFIV or pirfenidone were excluded. So they are like a biologic naive other than methotrexate or mycophenolate. Next. And the dose of reduction, the adjustments in the dose of OFIV was permitted between 150 and 100, according to the adverse events, which will be highlight in the upcoming slides. Next. And the primary endpoint was the annual rate of decline in the FVC per year, assessed at over 52 weeks. And there was multiple secondary endpoints, change in the modified rodent skin score. They looked at disease PROs such as HAQ-DI, SGRQ, CRIS. Next. It was a very comprehensive study. And they looked also about if there's they looked at measures of decline, annual decline in the FVC over 52, delta change in the FVC at 52, multiple kinds of analysis, whether it's lung, skin, or digital ulcers. Next. And also they looked at PROs, health-related quality of life, CRIS, and they looked also at mortality. Next. And it was a multi-center trial geographically from different North America, South America, Europe, and Asia. So it was representative throughout the globe. And what I like in this study, next, it is represented to what we see in our clinics. There was two arms. There was the treatment arm, which is the OFIV 150 twice daily, and the placebo. After randomization in each arm, there were 288 patients. Next. Next. And it's representative to what we see in our clinics. And we know that most of those patients are females, and similar to what we saw in our cohort, about 76% of the patients which were enrolled in the study were females. Next. Middle-aged, range at the age of 54. Most of them were diffuse, but this also applies to the rule that so ILD is not only for diffuse cutaneous systemic sclerosis, also can be seen in limited. And this, shows supports that notion that in this study, 53% of patients had diffuse cutaneous systemic sclerosis, and 46.9% of them had ILD in patients with limited. So I think screening should be unified to all patients with scleroderma. Years of since the first, so it was of early disease, and this is the importance of diagnosing early and starting treating early. And as you can see here, the median time since first Raynaud's was 3.4, and not all of them were on a DMARD. Only 48% were on mycophenolate, and only 8% were on methotrexate. So the message from this, that not all patients should be on a DMARD before starting OFIV. Still, you can start OFIV as a first line, even though they were not on a DMARD, whether mycophenolate, methotrexate, and I think you can apply this to all disease-modifying drugs that we use in ILD. Next. Again, they had a mild to moderate lung disease. FVC was 72% predicted, and DLCO was 52% predicted at baseline. Next. And they looked at the modified rodent skin score. Again, this is, I think it goes up to 54. This was, the skin scoring was maybe mild, because I think this is early in the disease. And sometimes early, it's hard to, I think this is the average that you see usually within the first 3 years. And they looked at digital ulcers, the burden, digital ulcer net burden. It was very low, and because they were excluded, I think, from their, it was part of the exclusion criteria to have severe or more than 3 ulcers. So this had minimal ulcers or just fissuring of the tips of the fingers. Next. So the primary endpoint was the annual rate of decline over 52 weeks. And for a fact, we know that normally every day we lose some lung capacity over time, and the average is between the 14 to 65 normally, without having ILD, and this depends on the age. But the older you are, you lose more annual force vital capacity. And imagine with having an ILD, I think this is like a cumulative effect, that you have more decline. I think I look at this as the lupus nephritis. The more they have attacks, the more they lose nephrons. And as you can see here clearly, that the adjusted annual rate of decline in the FVC in the patients treated with OFIV was -52, compared to the placebo was minus 93. And if we look at the delta change, reduction was 44%, which was statistically significant. It's a very impressive study. I don't think we will see any, and I don't think any of the other medications that I have seen that has this impressive decline in the annual FVC per year. Next. If we look at secondary endpoints, so modified Rodnan skin score was a secondary endpoint, not a primary. Next. And again, there was a minimal decline, but I don't think it reached significant. Numerically was minus 2.2, but the delta difference was not statistically significant to achieve a p-value of less than 0.5, but we see a minimal. And these diseases are very challenging. I mean, having a 52 weeks primary endpoint, is it enough to assess the skin? And this is always the question that we are challenged when we design trials with scleroderma. And when I speak to Dinesh, he said sometimes we need a longer duration to assess skin. It's very challenging to justify that duration and tells you, does it work on skin or not? And maybe down the road, if we have a more longitudinal data of over 3 to 5 years, and this will reassure us whether does it work on the skin or not. Do we need to give it more time to work on the skin or no? Even if you give it 3 years or 5 years, is not enough to work on the skin. Next. Other secondary endpoints, which are more PROs. Next. Again, we see a numerical improvement in the one of the quality of life as GRQ 0.8 compared to -0, but I think still it did not reach statistical significance. Next. If we look at the FACIT dyspnea score, it's a score that says dyspnea. Again, we see a numerical improvement in the patients treated with OFF compared to placebo. Again, the difference was high, but it did not achieve statistical significance of 0.2. Next. And if we look at the HAQ-DI, again, more patients who were treated with OFF had a better HAQ-DI compared to the placebo. Next. And if we look at digital ulcers, or patients with OFF, again, had less digital ulcers burden than patients of placebo. And again, I think this with time would give us more reassurance for that if we can use it in patients who also have digital ulcers. Next. Time to death, I think the percent was numerically equal, percent with events. Between the placebo and OFF, there was no signals that the patients who were on OFF are more or are at high risk of having death over the whole trial, or there's decreased death in the ones who were treated with OFF. Next. What are the most common side effects clinically in my practice? We see diarrhea, and this is very manageable. Either there's ways to overcome this, either to adjust the dose 100 milligrams daily, and then escalate the dose to 100 milligrams twice daily. And you can adjust also the diet. There's, I think the package comes if you go up to date, it tells you what kind of diet you can use. And sometimes you use loperamide, but it's very tolerable. Most of the patients, I have 1 or 2 patients that have diarrhea, and it improves over time. It's not like colchicine or other medications it's very tough to treat. It's very manageable. Nausea is another thing, but again, maybe at the beginning of the treatment, and over time, patients get more used to it. And I don't see the others such as URI, fatigue. I didn't see them, but also they're reported in the trial. Next. GERD, pyrexia, dizziness, all these were reported, bronchitis, but again, the patients that I have, the most common is loose stools. Next. Take-home message, I would like to end with this message. Often reduced ILD progression in patients with systemic sclerosis ILD, as demonstrated by significantly lower rate of decline in the FVC over 52 weeks when compared to the placebo. The relative effect of OFIV versus placebo and reducing the rate of decline was 44%. OFIV reduced ILD progression across patient subgroups with different baseline characteristics, very representative to what we see in the clinic, including patients with both limited and diffuse cutaneous systemic sclerosis, whether they were on mycophenolate, methotrexate or not. Still, you can use it as a first line or you can use it as an add-on, it doesn't matter. There was no effect of OFIV on skin fibrosis. Whether time will show us that it will work on skin or not, I think we need to wait for further studies. And as expected, based on the underlying disease, GI adverse events were the most frequent in patients with systemic sclerosis ID than IPF. And over 80% of patients in the census trial remained on nintedanib. So the retention rate is very high. And we see this at the clinic. I think most so far over the last 2 years, none of them stopped the medication. I think the retention rate is very high, well tolerated. Next. With this, I'd like to thank you for your attention. Thank you very much.
Thank you, Dr. Guy, for a very nice, comprehensive overview of scleroderma and the management. I don't know, listening to your presentation, from the start, we have like 190 plus patients in the UAE in the database, right?
Yes.
Which makes it almost like an orphan disease, even though, it should be higher, the percentage according to what should be seen. On the other hand, I see the societies that looking after this are lost. The GRAPA approach into classifying the disease into different facets and then how long should a patient be on like MMF before moving on to the next, and what are the criteria? This disease is like left to recommendations, then there are no real guidelines that shows the physician when to move. It's still like, depends on multidisciplinary approach to take it to the next step. So the rheumatologist does not have the full freedom to go on, move from, drug A to drug B and so on and so forth, unlike the other diseases. So what's your take, please?
So, as a rheumatologist, I think our role is to screen patients. That's the main role. And we have a similar algorithm that we just, implemented that it's like domains. If you so when the first patient comes, the first thing you screen the heart, you do an echo, you do a PFT and ILD, you do an upper endoscopy or a barium swallow to assess esophageal dysmotility. You do an RNA-3 polymerase to assess kidney involvement, and so it's. I think our role mainly is to screen patients to identify the disease early. That's what I think our main role in this disease. It's very challenging to have a one hand here to treat the patients by yourself. With ILD, as you mentioned, you need the help of pulmonary. With the skin, you need the help of dermatologist. With heart, you need the help of cardiologist. With GI, you need the help of GI involvement. You need the help of a gastroenterologist. Very challenging by yourself to manage those patients. Very demanding. They're very time consuming, honestly. You can spend an hour with them in a 20 minutes clinic. And at the end of the time, they are lost and they don't. They need time. I think that's what also the other thing that I think they are complex patients. They need an extra time to spend with explain to them the importance of screening, because they're overwhelmed with screening. Also, why do you want to send me to 3-4 doctors at the same time? Why you want to do all these images? I don't have shortness of breath now. Why? And it's very hard to explain to them why you want to, identify the disease earlier than later. So I think by yourself, it's very hard to treat those patients. You need the help of a multidisciplinary team.
Yeah, I do. Like in my clinic, I do collaborate a lot with Dr. Bassam Mahbub, of course, in the public and private. Like today, I had 2 cases between me and him. But the thing is, there is no guidance on how long should you put the patient on a particular conventional synthetic DMR before moving on.
True. Yeah, and this all comes from the experience. Last time when Dinesh kind of gave a lecture, he said, I used to tell patients 5 years and then you stop the medication. And he found out with his experience that if you stop the medications after 5 years, they relapse. And now he tells them for good, to take the medication for good. So I don't think we have a defined guidelines, whether, number one, when to start the treatment. As you see, there's different guidelines. As a clinician, I get lost when I read them. I don't know how to apply them clinically, and they're not easy to apply. Second thing, and for how long do you want to take the treatment? Third thing, combination treatments, giving CellCept with rituximab, giving CellCept with tocilizumab. Sometimes it's challenging if you want to add it, OFIV and other treatments. So I think even the combination sometimes is challenging. Which ones do you want to combine? And when to stop. So these 4 questions are very, very challenging. I think not to us. I mean, it's an international thing.
Yes.
And I think this where comes, I think we should be leaders with this. We should all of us sit and maybe do start this as leaders in the community to have from our experience dealing with this disease and how to approach this disease and answering these 4 questions.
Yeah, it's not getting the attention it deserves from both clinicians and the patients, and more attention needs to be given to this disease, I think.
I agree.
Thank you very much, Dr. Rajai, for a very nice presentation again. And for our next speaker, it gives me great pleasure to present Dr. Yusuf Dairi, who has graduated from Aleppo University. He finished his internal medicine residency and pulmonary medicine fellowship from University of Louisville in USA, and is currently a consultant pulmonologist at Rashid Hospital. So without further ado, Dr. Yusuf.
Assalamu alaikum wa rahmatullah. Thank you for the nice presentation. It's an interesting topic. I mean, talking about the connective tissue disease in relation to interstitial lung disease, the intersection between different specialty, is a bit challenging. So to follow on the scleroderma, so after the success of the study using antifibrotics in interstitial lung disease caused by scleroderma, the next step was to explore further connective tissue disease. And this is what the concentration of this talk will be about. All right. Yeah. So I'm contracted by Boehringer to give this talk, but I'm going to try to make it as inclusive of topics interested to both pulmonologists and rheumatologists. So in general, we're talking about interstitial lung disease. It's a very big bag of diseases that will affect the lung in general. Some will put it depending on what's causing it or how it behaves, how it looks like. It's not very common, so that's why you see some pulmonologists have superficial knowledge of it. Non-pulmonologists, anything that involves the lung, they call it just lung fibrosis, and they kind of lost in how to manage it. This scheme probably is the most accepted how we look into interstitial lung disease. We have a group that we know there's an etiology for it, the autoimmune, hypersystem pneumonitis, and sarcoidosis and other specific lung disease. And then we have this group of idiopathic that we don't know what's causing it. And we call it idiopathic after we have ruled out everything. Today, our talk is going to be concentrating on this group, the autoimmune interstitial lung disease. Scleroderma was covered with the previous presenter very excellently. But then we have another group of different connective tissue diseases that can cause interstitial lung disease. And we're going to try to see what can we do for these groups of patients. There's a new entity, what's called IPAF, which is interstitial lung disease with autoimmune features. So this is a newer classification. I think 2015 was published, where they're looking into groups of patients that have some autoimmune features, but they do not fit a specific diagnosis. You cannot call them that this is rheumatoid arthritis or scleroderma or any specific diagnosis. So they usually have some clinical features. So they might have Raynaud's phenomena, some of the palmar telangiectasias, ulcerations, edema. They have a specific digital fissuring, the mechanic hands, or a specific rash, fixed rash in the digital extensor surfaces. And they have sometimes just inflammatory arthropathy, but they still don't fit a specific diagnosis. So I think a lot of our colleagues in rheumatology would recognize the mechanic hand, and then this is the fixed rash on the extensor surfaces. When it came to serology, also non-specific. So they might have elevated ANA, they might have elevated titers almost of any of the antibody associated with different illnesses, but they're not specific to be called a specific diagnosis. So sometimes when I see a patient with interstitial lung disease, I'll do connective tissue disease workup. I get some of these elevated. They don't fit any specific criteria. There's no specific arthritis. And I send them my colleague rheumatologist. They come back and say, well, there is no rheumatic disease. So these are kind of group of patients. I'll be calling them IPAF. They're on the CT scan. They might have different features. Here, it's not the typical fibrosis you will see in IPF, what we call UIP. There's ground glass opacity, some fibrosis, but there is no the honeycombing that we see it specifically. It might look like organizing pneumonia, a little bit haziness in the lung. Sometimes they got these cystic changes that we call it lymphocytic interstitial pneumonia. So they have these patterns. So these are the IPAF that will be included in this group of patients. So whether they have a specific connective tissue disease diagnosis or not, they included here. Now, how common is it to have ILD in connective tissue disease? It's not very rare. I mean, you look at it, the diseases, it's anywhere, it's close 25 to 30%, depending on the disease. The scleroderma was covered. We can get up to 30% of the cases that will have interstitial lung disease. The one we see more commonly with rheumatoid arthritis, and it's just because of the sheer number. There are more people with RA than with scleroderma. We end up seeing more people with rheumatoid arthritis. But almost any connective tissue disease can be associated with interstitial lung disease. And as our colleagues were talking about how there's a delay in scleroma diagnosis, 9 months, 12 months, so on. It's not only for scleroderma, almost for all connective tissue disease, there's a delay between having symptoms until it's finally categorized and the treatment is started. And there is a lot of aspects of it. So sometimes it's the symptoms that triggers the workup. Sometimes there's a physical finding on examination, but until they get pulmonary function test, high resolution CT scan, it can be missed easily. There's a lot of things happening to trigger the fibrosis. This is the end result when you have a lot of fibrosis happening. But there's a lot of things that can happen between the injury that happened to the epithelium or the vascular injury, and then triggering the inflammatory response, and that inflammatory response triggering the fibroblast, and then the end result having this fibrosis. And our colleagues, the rheumatologists, trying to work on that early part, trying to control the inflammation, the autoimmune inflammation, and a lot of times we as pulmonologists involved when the fibroblasts get involved and we starting getting fibrosis early or sometimes late. When we're talking about what kind of workup you need to do for connective tissue disease related ILD, the symptoms can be non-specific, but the two ones that are very common are the dry cough and the progressive dyspnea. They can have Any other symptom related to their connective tissue disease, depending. You can see arthralgias, fatigues, pains here and there. A lot of times on radiology, the chest X-ray by itself is not specific and miss a lot of findings. And by the time you find it on X-ray, it's late. The high resolution CT scan tends to be more sensitive and specific, directing the physician that we have a problem here. Pulmonary function test is easy to do, whether you do just simple spirometry, you're looking at forced vital capacity or forced expiratory volume in 1 second. And if you want an expanded one where you get lung volumes and diffusion capacity, that gives you even more information. There are different ways of questionnaires asking patients about symptoms. This is one of the questionnaires that was in collaboration between the Chest Foundation, the American College of Chest Physicians, and Bergen Company. And we start adopting it in Rashid Hospital to make it more formal, asking the patient about their symptoms, about their comorbidities, about underlying illnesses, about medication they took, exposures, and so on. So it helps to have a form that will help you identify patients that have ILD early on. And then there's a list of exposures and medication that could also be a triggering factor. When we talk a lot of times about patterns on CT scan, it can be a little bit confusing. I'm trying to simplify it here. In the top here, this is the usual interstitial pneumonia pattern, the one you see in IPF, but could be seen in rheumatoid arthritis. This is the most severe. Usually, you're going to have the reticulation. These are the white lines you'll see on CT scan. You'll see a lot of damage, look like honeycombing, and then there was bronchiectasis. When there isn't a lot of honeycombing and more ground glass opacity, this is a non-specific, this is NSIP. You can have organizing pneumonia. So without having these extensive fibrosis early on, there will be more like ground glass opacity, a little bit nodules. It could be a little bit more consolidation. So these patterns sometimes will direct us into what's happening. So this is the fibrosis, the typical fibrosis that we'll see in IPF and advanced cases of rheumatoid arthritis. But this is the case you're going to see in organizing pneumonia. It's not a lot of fibrosis, but there's a lot of inflammation, ground glass opacities. Non-specific NSIP, again, you don't see the honeycombing, but there is a lot of ground glass opacity. You see the interstitium starting getting a little bit thicker. With the lymphocytic, you see more like cystic changes, cases of acute interstitial pneumonia, sometimes in acute exacerbation of ILD in connective tissue disease. They look a lot of inflammation with a background of fibrosis. The pulmonary function testing, beside what we do for spirometry, volume, and so on, we're also checking their oximetry, resting, on exercise, the distance they can walk. That all will give us an idea about their functionality. Most time it's a restrictive pattern, but sometimes you might have somebody have underlying lung disease. They're a smoker with emphysema, so when they get the restriction, it doesn't show that much. The reduced DLCO, the diffusion capacity, can be an early sign even before you can see fibrosis on the CT scan. But there are other reasons for decreased DLCO, connective tissue disease. The hypoxemia by itself can cause pulmonary hypertension. There are specific diseases that cause primary pulmonary hypertension, cases with the scleroderma, and they can have thromboembolic phenomena, like you will see with the lupus and lupus anticoagulants having recurrent pulmonary embolisms. So here we're talking about the lung involvement in connective tissue disease. We can have an ILD, where we're going to have inflammation or fibrosis from the disease itself. And here where you can have the clinical picture, high resolution CT scan, pulmonary function test help to identify it and quantify it. But sometimes drug toxicity, and the best example of that, methotrexate and sometimes becomes challenging to when you start having fibrosis. Is it because of the disease? Is it because of the medication? Pulmonary hypertension, which can have several etiologies. Normally, it's screening done by echocardiography, but it could be due to pulmonary hypertension. We have some cases where there's cardiomyopathy that will cause pulmonary hypertension. Hypoxemia itself can cause that, and then the chronic pulmonary embolisms also can cause pulmonary hypertension. So how we monitor? I like the previous talk when talking about different schemes for following patients with systemic sclerosis, when you should check TFTs, high resolution CT scan. I think on presentation, all these patients need to be assessed. And depending on their progression, you might opt to do that even if they're asymptomatic annually, and if they have symptoms, even more frequently. And having collaboration with the pulmonologist, having follow-up with them, it depends on the course of the patient. They can decide how frequent these need to be done. With pulmonary function testing, the number that's mostly used is the forced vital capacity. Easy to be done. Usually this parameter is small. Almost all pulmonologists has it, so it's easy to follow. The diffusion capacity usually requires a little bit more extensive machines that are available in hospitals, not in doctors' offices. High resolution CT scan became very frequent, very available. So the combination of two of them would be more sensitive than either one alone. There are cases where you have early changes in diffusing capacity before you can see it, obviously high resolution CT scan, or vice versa. You have changes in high resolution CT scan and the PFT is still normal. So the combination helped a lot. When it comes to progressive fibrosis, so this is the challenging. So you have a patient with connective tissue disease, they have an early fibrosis, like you see here. They have early changes, you have reticulations, subpleural reticulations, and you decide, okay, is that somebody I need to give them antifibrotic or not? And this is where the concept of progressive fibrosis, is this stable or this is progressing? Is that a scarred off lung? And now that the patient inflammation is totally controlled with the disease modifying agents, or is it something that's still progressing despite controlling the inflammation? So in this case, like 12 months later, we can see that the fibrosis was progressing. The left lung was clear. Now we can see it starting getting involved. The right lung started having more fibrosis. So that's where in connective tissue disease, it's not enough to have fibrosis or interstitial lung disease to right away trigger antifibrotics. We need to see, is this progressive or it's not progressive? Here, the different patterns, again, about a patient starting with a baseline that looked like usual interstitial pneumonitis, what you normally see in IPF or rheumatoid arthritis. And 12 months later, you can see it getting more extensive. The bronchiectasis is getting more extensive. You can see the bronchi getting more widened. You can see more involvement of fibrosis. So this is on radiology by itself can be considered progressive. So, and that's where came the idea, okay, can we do something for this fibrosis? We know from the census trial that was done for scleroderma that antifibrotic nintedanib had an added value of slowing the progression. So the idea was, okay, how about other diseases, not only scleroderma, all the bag of connective tissue disease? Can we use nintedanib in these cases? And so they run this inbuilt trial, which was similar design. So you have two groups. You're going to do placebo versus nintedanib, 52 weeks, standard dose, 150 milligram twice daily. And then you see at the end of 52 weeks, 1 year, how is that going to be doing? The inclusion criteria are very similar. You're talking about adult patient, looking at physician diagnosed interstitial lung disease other than IPF. So they want to include all diseases that will cause interstitial lung disease beside IPF. And they need to have fibrosis So initially, they need to have something at least 10% of fibrosis in high resolution CT scan before they're going to consider it to be fibrosis or interstitial lung disease. The disease, they try to get it not to be very late. So FVC more than 45%, less than that, that's really too late. You might not see a difference. And with the diffusion capacity, trying again not to have it the worst, to be less than 30%, between 30 and 80%. And so they put an interesting diagnosis. What is progressive disease? I know with the scleroderma, Dr. Raja was saying that you have different studies giving you different numbers. Here they use simple number, easy to follow. So if you have a patient within the last 24 months, in 2 years, they have a decline more than 10% of FVC, that's progressive. If it's less than 10%, between 5 and 10%, but they have other things going on, either the respiratory symptoms got worse or their high resolution scan showing it be worse, is considered progressive. If the FVC was not changing, but both the CT scan and the symptoms are getting worse, this is progressive. So I think this definition criteria make it easier for clinician to follow. Yes, my patient have progressive phenotype because I can tell FVC had dropped more than 10% in the last 2 years. And if not 10%, then I have something else. Symptoms are getting worse, or there is a high resolution CT scan evidence of increased fibrosis. They excluded the patient with IPF because already we know that nintedanib works for IPF, has an indication for it. So they did not want to contaminate their sample with IPF. They made sure it's not an obstructive disease. This ratio here will indicate that the patient have obstructive disease like asthma or COPD. So they excluded them. They made sure that there is no liver involvement, because that's part of the monitoring of nintedanib, make sure it doesn't affect the liver, so they don't want anything affecting it. And again, some patients with the anticoagulants with nintedanib, there could be some interaction, so they excluded these patients. And those with significant pulmonary hypertension also excluded, because it's going to make it difficult to find what's worse for the patient, pulmonary hypertension, ILD. So they want to keep it clean sample. They want only the ILD without the pulmonary hypertension. And similar to the census trial, patient was allowed to have disease-modifying agents as long as they've been stable. They're not changing it in the last 6 weeks. And they want to make sure that they had not been treated with antifibrotic in the past. And depending on their disease-modifying agent, the time for them, whether it's 4 weeks or 8 weeks, depending on the half-life and effectiveness of the medication. You see with the rituximab, they want at least 6 months. The dose hasn't been changed before they're being involved. The dose is the standard 150 milligram twice daily. If they have symptoms like diarrhea, they were allowed to go down to 100 milligram twice daily. Interruptions could be allowed, but not to be very long interruptions. When the patients included in these patients, those who had UIP-like fibrotic genes, these are the most fibrosis you will see, or those who have other forms, which is usually milder, you're going to see more like inflammation of the lung. So they included both categories of patient to see would that make a difference. Is the antifibrotic going to work only in patients who have a lot of fibrosis, or those who have early inflammation and early fibrosis? And as we will see in result, it worked in both kind of patients. So they have two co-primary analyses: the UIP pattern, the ones with the fibrosis, and the ones without UIP pattern with less fibrosis. They looked at here, they used different questionnaire for quality of life than the St. George, the one they used in the scleroderma, but the end results about the same. They looked at the first acute exacerbation of ILD or death over study, 52 weeks, and the time to death. So the definition for an acute exacerbation of ILD, this is an entity where a lot of time it's confusing for both pulmonologists and rheumatologists. When you have somebody all of a sudden having hypoxia, increased symptoms, you do an X-ray or CT scan, and then you see increased ground glass opacity. This is by definition is acute exacerbation of ILD, as long as it's not infection and it's not fluid overload. So that's serious. In IPF, the mortality was at 80%. In connective tissue disease related ILD, the mortality is close to that also. So it's a very serious incident when it happens. So they look at it whether having antifibrotic nintedanib will decrease these acute exacerbations. The patients, when you look at it, they have patients who have rheumatoid arthritis, scleroderma, mixed connective tissue disease. Between these three categories, you have about 30% of the patient included there. Oxygen was fine when they were resting, but when they are exercising, that's a different issue. So when they looked at overall population, what they're taking, whether DMARDs or steroids, 57% of these patients took it. But remember, not all of them have connective tissue disease. When we come to connective tissue disease, we're going to see that percentage being higher. The annual decline in FVC without the treatment, just with the placebo, the patient declined 187 mLs. You can see this rate was much higher than the one you see in scleroderma, which is about 90 something, just because this disease is more significant elderly patient. But nintedanib was able to cut that decline about 57%. When they looked at patients who have the most fibrosis, the UIP pattern, the nintedanib has an effect of 61% decreasing that. Those who did not UIP still was effective almost 50%. So whether they have a lot of fibrosis with the UIP pattern or less fibrosis with the non-UIP pattern, still nintedanib showed an efficiency of close to 50%. When they have fibrosis, more than 60%. When they looked at the change in FVC, very early on, within 2 weeks, you can notice that the nintedanib starting to stabilize, slow down the loss of lung function. So it was relatively quick response that you will see within a couple of weeks, and then continue it for the rest of the year. And this is the interesting thing, having steroids or DMARDs, it was synergistic. So when patients have steroids or other DMARDs on board, then nintedanib had a lot of effect on slowing down the fibrosis. So it's synergistic effect. You can treat both at the same time, the inflammation and the fibrosis. So once you decide your patient have progressive fibrosis with connective tissue disease, you can work on both ends, and there's no contradiction. In fact, here you see more synergy about using the two together. With the quality of life questionnaire, there was a trend for improvement, but it did not reach statistical significance. When it came to acute exacerbation of ILD, and it said this is really a serious problem, nintedanib, it took a little bit longer time to see that effect, just because acute exacerbation are not very common. But by the end of the study, there was a clear difference where nintedanib have decreased these effects. Statistically, it was not significant, but numerically, there was about 60% patients were more likely not to have an exacerbation. When they look at the specific subgroup, patients with connective tissue disease, autoimmune disease, which is related to our talk today, we see more now, it's shifting towards being females, the patient. Surprisingly, 50% of them current or former smokers. That's probably reflects the recruitment population in Western nations, where it's more common for females to smoke. And this, the same proportion being white and Asian, where they recruited their patients. When they look at the subgroups of autoimmune disease, the majority were rheumatoid arthritis. And that's will reflect probably what we see in our practice. Most of the patients I see with connective tissue disease-related ILD are rheumatoid arthritis. The second group will be scleroderma, and then we have the mixed connective tissue disease. When they looked at steroids and DMARDs, here we can see 77% are taking something to modify the disease, whether the majority of them taking steroids or other DMRs, and were they taking also biological. And the rate of decline in FVC was cut down. Again, here we have seen nintedanib had 58% less reduction. So without the treatment, this group patient, they were losing 178 mLs a year lung function. It cut it down to 75 mLs. What does that mean? It means that the patient would reserve lung function for longer period of time. If somebody is losing 170 mLs a year of lung function, in 10 years, they lost 1.7 liters of lung function. And that means that patient by then severely affected, hypoxemic, lung transplant, or probably die. If you can extend that lung reservation for longer period of time, you can have patients in their 60s. So instead being incapacitated in their 70s, now you're extending it to their 80s and so on. So that will give them closer to a normal lifespan. And whether they're using, again, steroids or other DMARDs, we can see this synergistic effect. When they're using, they have even better protection when they're using their DMARDs, probably reflecting that the physician chose to give DMARDs or steroids to patients who have more active inflammation. And with nintedanib, it's not only an anti-fibrotic, it has different mechanism of action. Part of it is as an anti-inflammatory. So there's synergicity in their effect. The safety, it almost reflects what we've seen with the census trial. Diarrhea is the most common. And again, the management is almost the same, adjustment of diet, sometimes reduction or interruption of the dose, but it rarely would affect the patient taking it or having to stop it. Elevation in liver enzymes, usually it's mild, about 3 to 5 times the upper normal, and interruption usually corrected. Very rarely it was severe where they have to stop it, the medication. So with the ILD trial, the endpoint was met in both primary population, whether it was with UIP pattern, the most fibrotic, or non-UIP pattern, the ones with less fibrosis, both of them have reduction in the loss of lung function over the study period of 52 weeks. So that, again, carried that this medication, nintedanib, it's working not only in IPF, not only in scleroderma, but in any disease that has progressive fibrosis. Also with the acute exacerbation of ILD, it was decreasing it, which is also a significant outcome. The safety measures, I said, it's usually GI symptoms that are easily to be managed by diet adjustment, interruption or reduction of the doses. The liver enzymes, as I said, were not usually affected, and interruption or decreasing the dose usually helps managing it. As we've seen in the previous presentation with the nintedanib working on different targets. So it's not only an anti-fibrotic, being an anti-inflammatory, working with the tyrosine kinase inhibitor, have different effects on other substances. And down the years, we're probably going to understand more about which of these effects having the most results clinically. But we as physicians, we've seen where these medications help in our population once they have fibrosis with or without inflammation. We've shown this before, how it is complicated to have this inflammation and fibrosis. And I think I will stop my talk here and take any questions.
Okay, thanks, Doctor, so much for your valuable presentation today. And let's go through the questions that are already in the chat box. So first question related to, is there any treatment effective for calcinosis? So feel free, doctors, if you need
So I can say, you know, I see calcinosis in the UAE more than what I've seen in the US. And as we know, calcinosis is very challenging. We don't have guidelines to treat it. From my experience, colchicine, I tried colchicine, adding it to bisphosphonates, alendronate is most of the time helpful. Actually, we published one of the papers that we showed that there was a significant improvement in the calcinosis quantified by a dual energy CT over time. So I think colchicine and Fosamax alendronate is a good combination, very successful. Or the use of IV bisphosphonates also is good with colchicine. I don't see at all that much of Cellcept or rituximab. We used sodium thiosulfate at one time infusions, not too much success. I think there's an ongoing trial of sodium thiosulfate in calcinosis, ongoing currently, but still we don't know the results. But this is my humble opinion.
Okay, perfect. Second question related, what duration for MMF to be used for patients with scleroderma?
So are we talking about skin or lungs? So if we're talking about, so I'll let you know, my colleagues, I don't know. So it's a very, I mean, it's not like what we see with RA and lupus, where you start the medication and within maybe 6 weeks or up to 3 months, you see that improvement, and then you switch. First of all, with scleroderma, with mycophenolate CellCept, usually we start a low dose sometimes for a long period due to the GI upset. So it's hard to maximize sometimes that target of 3 grams of CellCept in those patients. We're talking about skin or even lungs. So it's very challenging to be on a maximized dose of CellCept, whether skin or lung disease. But usually, at least you should keep them for 6 months, and then you can decide whether there's an improvement in the lung, the lung function or the lung performance before judging whether to add or whether to switch. And usually I prefer adding than just stopping the medication and switching. I would like to hear from my colleagues, Dr. Ahmed and Dr. Youssef, their inputs.
Yes, for CellCept, actually, we don't have a definite duration. So usually, we have a chronic autoimmune conditions, and as long as the patient already still has a progressive disease, we'll continue until have a significant remission or significant control of the disease. The main point is still we don't know when to upgrade the treatment or exactly in scleroderma in comparison to other diseases that we have, in comparison to lupus and psoriatic arthritis and rheumatoid arthritis. We have guidelines that patient already continue on conventional DMARDs for some period of time, and if you're failing to get the objective target, we can switch or upgrade our treatment. I think this is the main point. But for the duration, I think there is no definite duration we can describe the duration of treatment.
I think from the pulmonologist standpoint, when we have a patient have connective tissue disease of any category, usually we kind of co-manage with the rheumatologist. So we let our colleagues take the lead with anti-inflammatories when it comes for the doses, duration, and so on, because there's more than just the lung involved in that case. And we'll be co-managing usually with antifibrotics, or if there is development of something else. Are we suspecting secondary infections? Are there other involvement, pulmonary hypertension, and so on? Now, in non-connective tissue disease, when we have like hypersensitive pneumonitis, when we use immune-modifying agents like mycophenolate, again, there's no specific duration. It depends on the clinical response and the patient's side effects, and there's no fixed regimen. It is tailored patient to patient.
I have a question. Since this disease is both inflammatory and fibrotic, using a biologic to tackle the inflammatory part and nintedanib to take care of the fibrotic part, was that even tried, or is that even possible?
I think that's part of the trial, that when the inbuilt, yes, the biological were allowed, and the patient taking biological, nintedanib was used to them and was as efficient. So it could be used. So, and we have patients on biological for rheumatoid or whatever disease, if they have still evidence of progressive fibrosis despite controlling their disease, whether biological or other DMARDs, then we start nintedanib. Yeah, it could be used, both of them.
The problem, I guess, we have in the insurance-based system, like we've been working in, there are no guidelines. This is our issue. I mean, even when using CellCept for lupus nephritis, we get hassled by the insurers, let alone when using for scleroderma, and then when you move up to tocilizumab or nintedanib. I mean, in an institution like the colleagues, both Dr. Namas and you, I mean, it wouldn't be that difficult. But for me and Dr. Ahmed, I think we have this issue a lot. I mean, even when trying to access TB therapy for patients who have latent TB, as per guidance, we have to refer them to public hospitals, and not no INH is available in the private sector. So there are so many things that need to be amended, I think, for patients, because what's happening now is that most of the patients end up in the tertiary public hospitals rather than being managed mainly, well, between the both public and private. So there is a disconnect that needs to be connected again, I think.
Yeah, I agree. I mean, for us, the prescribing mycophenolate for other than organ transplant, we have to go through a lot of hassles. But I think with nintedanib having FDA approval specifically for scleroderma and progressive fibrosis will make it easier. It's still not straightforward. Just being an expensive medication, you'll see some of the insurance companies try to fight it. But having an FDA approval label specifically for this indication, I think will make it easier to fight it and appeal it.
Yes, but still, as Dr. Walid said, on the insurance side and the private sector especially, to upgrade the treatment from conventional to an expensive medication, it is actually it's a tough job to get it even for one biologic. So, and most of this our patient already have significant part of them already in expensive medications. And adding another cost, I think this already need a clear recommendation or guidelines to be relied on, because most of the insurance companies asking for which guidelines you are following and which recommendation you are relying on to prescribe these medications.
And let alone like in rheumatoid arthritis or psoriatic arthritis, if they arrive early, you can give patients hope that after a number of years they'll come off the treatment. But when it comes to scleroderma, this is a treatment for maybe lifetime, and the insurances would not take it without some pinch of salt. They will not approve a treatment for a long period unless this kind of information is taken to the insurance companies. I mean, the insurance companies need to know about this. And this is the missing link. I think Boehringer can link with the insurance companies.
Yes, I think this is a very good point, valid point for awareness about the treatment for inflammation. There's a part different than the fibrosis. That's why we may need to, in some cases, we could have two options or two medications together.
Yes.
Yeah, and this is also we are working in parallel with you doctors for sure, with the insurance companies to, as Dr. Yusuf mentioned, to tell them about the new approvals of this new indication, so on. So in a parallel ways to have to ease your job at the same time, and at the same time to aware them for this new indication to accelerate the process, as you mentioned, that's been the private accounts. Thanks for elaborating for this. Also, there is one question related to can we initiate MMF and nintedanib directly in patients with systemic sclerosis ILD?
You know, I believe yes, we can. You know, the inbuilt trial, not all of the patients were on any DMARDs. So some of them they were biologic naive, and they were DMARD naive, and they were started immediately on offer. Clinically, we do it. Recently, just now, I think today we had an MTT meeting, and we just started the patient on office. So you don't need to be on a mycophenolate, a background mycophenolate, or methotrexate, or any of the medications we use. You just can go ahead with, if you think that's more a fibrotic process, more a lung process, and you are just targeting the lungs, I mean, yeah, you can just go ahead with office.
I think part of it is also the extent of the disease. So when you have patients coming most of the time late, they already lost half of their lung function. So sometimes you cannot afford wait and see for a year to see if they lost 10% of the lung function. But if you have somebody really early on, they still have 80% of lung function, still an inflammatory process, you want to wait. But as Dr. Rajai said, most time, by the time they present to you, you're really trying to preserve whatever they have. And there is no contraindication between concomitant use. And as you've seen in the study, there's more synergicity in the work. So it could be combined with no problem.
I think based on the data also, combination is much better regarding the achievement of the improvement in function, fortifies the vital capacity and halting the progression of the disease. If it is possible to do it.
There is also a question to Dr. Youssef. What is your experience in dealing with lung involvement in rheumatoid arthritis other than ILD, especially small airway disease, and how do you differentiate it from straightforward bronchial asthma with rheumatoid arthritis?
It's a challenging question. And we have patients who have both. So we have patients who have asthma before they were diagnosed with rheumatoid arthritis, which makes it easier. It's unlikely to have somebody in their 50s having a new onset asthma. But we have cases people are smokers and they have COPD and they wheeze, and now they have rheumatoid arthritis diagnosed. It can be challenging sometimes. And when we have wheezing or evidence of obstruction on pulmonary function test, we can treat both. I have some patients taking systemic anti-inflammatories, antifibrotic, and at the same time they're getting inhaled treatment, whether they're inhaled steroids or bronchodilators. So again, you can tailor it to your patient, looking at their profile, their history, and with the treatment, and see how the response is happening. But you can tackle different parts of the disease simultaneously.
Another question, in patients with rheumatoid arthritis ILD, is rituximab effective in reducing progression, or should we use antifibrotic?
Again, it is already about the pathology happening. We have two pathology running, the inflammation. Rituximab could help in the inflammatory part, but not for fibrosis. So it will not help in stopping the fibrosis, and could help only in the part of the inflammation, which is one stage of the disease.
With rheumatoid arthritis, we have a lot of the luxury of time. They're usually not as desperate as with scleroderma, and you can see their progression. Once their inflammation is controlled, with every agent including rituximab, and they're still having progressive fibrosis, then you say, okay, I have a clear indication for nintedanib. But we have cases where the fibrosis has been stable. You have somebody had mild fibrosis, and for over 4 or 5 years hasn't changed. And then you see some of them, people are buying one of these generic antifibrotics from overseas, and they're using it without a clear indication. So we need to differentiate between an old fibrosis, well controlled with anti-inflammatories, versus ongoing fibrosis despite anti-inflammatories. So these are when you're going to be considering, yeah, I need to give nintedanib because this is progressive fibrosis.
Thank you, doctors, for elaborating on this. Another question, what about methotrexate in ILD in systemic sclerosis?
This is a challenge.
Yeah, we do use it. We do use it in systemic. It's not a contraindication not to use it. Okay, what I do usually, if I'm desperate, I want to start methotrexate, I just do a baseline PFT.
Yes.
And then maybe down the road in 6 months, I repeat the PFT. And if I see a notable decline in the lung parameters, at that time I stop it. Honestly, I have maybe more than 3 or 4 patients that are on methotrexate with moderate ILD, and they're doing well because they have this inflammatory pattern of rheumatoid arthritis with ILD. It's like an overlap that Dr. Abu Gamal, he mentioned that sometimes they present with an inflammatory RA pattern. And the only thing that they benefit from as a steroid sparing is methotrexate. So it's not a contraindication not to use it, just be cautious. I mean, use your judgment. And most of the patients I had, they're doing well, actually.
What is the effect of nintedanib on DLCO, on carbon monoxide diffusing capacity DLCO? Improve, worse, or no effect?
I think the studies that were done, whether for the scleroderma or for the progressive fibrosis, they look more at FVC than DLCO because an easier target, and it's usually due to fibrosis. DLCO has a lot of things affected, not only fibrosis. So you have cases pulmonary hypertension can affect it, and thromboembolism can affect it. So it's not a pure marker. In general, you would expect it to improve. let's hold back. It will improve if the inflammation improves. So we have somebody decrease DLCO and they have active inflammation. You control the inflammation, you're going to expect the DLCO to improve. If the inflammation already controlled and they have decreased FVC and DLCO because of fibrosis, then you would expect nintedanib in this case will slow down the progression. It did not reverse it. But most of the time, the DLCO, the controlling the inflammation will be the most important in this case. But since the studies did not gear it toward, it's not a pure marker. We don't have a clear indicator. But clinically, this is what you would expect.
Another question for rheumatologists. It is amazing that the predominant ILD in rheumatoid arthritis is UIP, while for most other connective tissue disease is NSIP. Why do you think that the reason behind this?
For rheumatologists, sure.
Yeah, I see this. Yeah.
Because of the disease itself, it's more pro-inflammatory than it's a combination actually. So that's my take. Colleagues might have more to elaborate.
I think it's a different disease pathology. That's, you know, I know that in scleroderma, TGF-beta plays a major role, whereas in rheumatoid, it's more a B-cell driven disease. So it's just a different disease, underlying pathophysiology. So, and you know, so it doesn't mean that in scleroderma we don't see UIP. We do see UIP, but NSIP is more common, 75%. You see a small portion with UIP. And you know, at one time I think I asked Dr. Flaherty in Michigan that is it a progressive, that if you have NSIP, will it progress to UIP? He said no, it's a different, you know, pathophysiology. But you can have both pathogens, but the predominant pathogen is NSIP. So it doesn't mean that in the CT, it's just NSIP. You may have a little bit of UIP, but the predominant pathogen is NSIP. So,
hey, doctors, I know that we extended the time of the presentations, so only remain 2 questions. So if you would like to close the meeting or to go through them, it's up to you, doctors. Because
go ahead. Okay.
Okay, so there is a question. Any of the presenters has experience with tocilizumab implementation for treatment of progressive systemic sclerosis ILD?
Yes, I do. I have one patient on CellCept and tocilizumab, was refractory to rituximab. I inherited actually from one of my colleagues. And I think the main concern with such combination is just infection. I don't think we are still well aware of when to use tocilizumab in our patient phenotypes. I'm still challenged to say that this patient needs to be on tocilizumab. I'm more comfortable with CellCept and OFEV, and I'm looking. You know, whenever we go to meetings and meet Dinesh, and I always ask, whom are the patients that you put on tocilizumab? And still, this is a very challenging, you know, question. I have only this patient that I've used. I would like to hear from my colleagues if they have any.
I have one case during COVID, and it was the quickest approval because tocilizumab was used a lot. So I have one patient, but yeah, it was on. That patient was on 2 grams of MMF and tocilizumab as well. The rheumatology regimen for rheumatoid arthritis IV, and it worked. It worked. I see a lot of Syrian scleroderma for one reason. I don't see Emiratis in my clinic with scleroderma. I have few cases. I have one patient who she was limited for about 9 years, stable. Then suddenly to 2019, she just became rapidly progressive. But in her case, rituximab worked. She progressed rapidly. I mean, the Raynaud's, the skin, the lung, everything. I don't know what made her, switch from being stable. But tocilizumab, I have one case. But MMF is the drug that is dominating mainly in my clinic.
Yes, and all my cases of scleroderma already in MMF for chest, for ILD, they are fine. I don't have cases in testicular.
Okay, last question. Do you guys use nintedanib with a standard treatment like MMF or even further with rituximab when there is a plenty of fibrosis side by side with ground glass changes?
Yes, we do. I think, the question that most of the audience should ask is I think the patient should be aware of what the treatment is, and this is what I think the patient should understand what's the benefit of the treatment. When we start a medication, what will he benefit from? And this is what's always challenging, and this is what decreases compliance, I think. And I think, the first thing to tell the patient is whenever we start a treatment is that if we halt the disease or decrease the progression, this is it's an achievement. And if we improve the forced vital capacity, that's a success. I think that's, because the patients think that if he takes the medication, they will go back to normal. Like the lung function will improve 100%. And this, rarely happen. I mean, I think anytime we start the treatment for ILD, we always hope that there is no decline, number one, and number two, if there is an improvement, it will be a very successful story. So I think we do use OFIV with combination with rituximab. I think we should explain to the patients what's the importance of the treatments, what to expect, because patients are desperate. They start jumping from one doctor to the other. That's my take-home message, and they just need to know that I usually print it prints the graph of the forced vital capacity and the DLCO. And we show them that, I think if it's stable, that's a success. Don't get depressed. I mean, this is something good. And if it improves, that's, better. So I think that's the take-home message from, that we should tell patients what to expect, because they expect, it's like rheumatoid, they go back to normal, I mean, most of the time. But it rarely happens that the lung function go back to what they had before. So.
Perfect.
Thank you.
So, yeah. Thank you, Dr. Rajai, and thank you all doctors. So this is the last question. I have only one small question now. Is there any prognostic importance depending to the type of systemic sclerosis, like limited and extensive? This is the last one.
Usually the diffuse one have a worst diagnosis because they have high risk of the development of organ involvement, but still the limited have the high risk of developing pulmonary hypertension, which is a fatal complication also.
So this is the end. The floor is yours, Dr. Walid. Yeah,
but still you need to screen patients equally. I mean, don't try to say, don't differentiate between them. When you see them, initially, whether they're diffused or limited, just do the full workup for ILD.
Yes, because both included, yes.
Yes.
Okay, so thank you very much, everybody, for a very nice meeting. Thanks, Boehringer, for the support. Thank all of the speakers for taking their time to answer the questions and give the talks. I thank the attendees, of course, for their perseverance for this meeting and for their nice questions. Hoping to take this to the next level in the upcoming meetings. Thanks all, and have a good night. Stay safe and stay healthy. Good night.
Sorry.
So.